Hey, BC here for BCNephro. Today's topic, talking to patients and their families about dialysis. This video will address issues for patients with chronic kidney disease who are progressing toward end-stage kidney disease that would require renal replacement therapy. For patients with acute kidney injury, patients hospitalized with critical illness, there are different issues that won't be addressed in this video. But for a patient with chronic kidney disease, let's get into it. Here are some of my experiences for the following issues. One is when to have these discussions. Two, how I answer some common questions and concerns that the patients have. And third, some pitfalls that I've come across and how I address these pitfalls. So first, when to have these discussions. In my opinion, these discussions should be had when the GFR is less than 20 and there's any degree of overt proteinuria that is an albumin to creatinine ratio greater than 300. And that is for two reasons. First, for a patient who may be a kidney transplant candidate, they can be listed preemptively for a kidney transplant when the GFR is less than 20. So it is appropriate to get this evaluation going, see if they have any living donors, and have them listed and start accruing time if they don't have a potential living donor before they end up needing dialysis. Second, we need to start dialysis modality, education and planning, that is hemodialysis versus peritoneal dialysis, and access planning. So especially a patient for hemodialysis for whom a fistula may be recommended. For this reason, it's recommended that if the kidney failure risk equation has a 2-year risk in the 20 to 40% range, that the patient is referred for access planning. Most patients with a GFR less than 20 and overt albuminuria are going to fall in this range. You can do the calculation for your patient. Specifically, a link to the calculator will be in the description below. Second, for younger patients, it's often clear that they're going to want to do dialysis, but for older patients, it may not be clear. They may want to know some things. So one thing they often want to know is, how long will I live with dialysis? How long will this extend my life? Now, this is a difficult question because, first of all, most people in general think they're going to live longer than their actual life expectancy is. So for this reason, I look up the Social Security Actuarial life expectancy based on age. A link to this table will be in the description below, but do it for yourself. Think of how old you are and think of how old you're going to live and compare it to the calculator. For me, the average life expectancy for my age is 10 years younger than I think I'm going to live to. Now, patients on hemodialysis, on dialysis, the life expectancy is much lower than average. There will be an article at BCNephro.com and a link will be in the description below that will list the Social Security Actuarial data with the dialysis U.S. renal data system life expectancy data based on age. But essentially, for a patient on dialysis who is 80, the life expectancy in the ballpark of 3 years, 70 in the ballpark of 4 years, 60 in the ballpark of 6 years. And this is going to be less for patients with congestive heart failure, coronary artery disease, peripheral artery disease, history of stroke, and it might be better for if your patient is fortunate enough not to have any of these comorbidities. Second is, how are they going to feel with dialysis? So dialysis is expected to improve uremic symptoms and symptoms of volume overload, but it comes at a cost, a symptom burden. One way I think about it for my specific patient is what their GFR is like. So if their GFR is greater than 15, their symptoms are less likely to be severe uremic. They may be caused by other things, and I believe less likely to improve than if a patient's GFR is less than 10, where it's more likely to expect them to improve. I'm upfront about this, where if the patient's GFR is less than 10, I tell them I expect these symptoms to improve. Where the patient's GFR is above 15, or maybe in the 10 to 15 range, these symptoms may improve, but I'm not sure how much they will improve. The second thing, it has to do with frailty. So if a patient is frail and has difficulty with functional status, their functional status often does not improve with dialysis. The second has to do with symptom burden. So there are intradialytic symptoms, hypotension, cramping, nausea, headaches, but there's also dialysis itself is draining, and I counsel patients to expect a need for recovery time after dialysis. So there's some time after dialysis where the patient's going to feel drained, weak, and tired. Now that time may vary based on the patient. So a younger, healthier patient, that time may be very, very short, 30 minutes or less. But for an older patient with comorbidities, that time may be very long. It may be the rest of the day. And then by the time they start feeling better, it may be time for the next dialysis session. I counsel patients that this occurs. I cannot predict how long their dialysis recovery time will be. But if we do dialysis and the recovery time is long, then they can maybe reassess whether the trade-off is worth it for them and whether they want to continue on dialysis. Third, pitfalls. So I find a lot of these pitfalls have to do when the question is simply asked, do you want dialysis, as opposed to a more shared decision-making approach. So when a patient's asked, do you want dialysis, often the answer is no, which of course no one wants dialysis. But if you press this a little further, a lot of these patients don't want to die either. They'll end up saying, I don't want dialysis if I don't need it. This is something that's, I believe, is important to clarify, because if it's not clarified or addressed, you can end up in pitfall number 2, which is a failure of modality and dialysis access planning. So if a patient is not addressing the decision about dialysis, the need for that decision doesn't go away, and it actually accrues interest with time. Not addressing this and not choosing modality and getting access placed increases the risk of the need for emergency dialysis, hospitalization, the need for a catheter, and complications, infections related to that. And I am upfront with the patients about this. Now, the third pitfall has to do with an either-or decision and ending up classifying the patient as not wanting dialysis or refusing dialysis, which is terminology that I personally don't like. It's reasonable, especially for older patients, to continue to treat them and do the best you can to extend their life and make them feel as good as possible for as long as possible, but stay short of an invasive treatment like dialysis. And I present it in this way. We can continue to treat you medically and try to keep you alive for as long as possible and feel as well as possible, understanding that it might be a little bit shorter than if we did dialysis. And for many patients, this may be a reasonable choice. And the truth is that in older patients older than 80, the length of time that they stay alive is attenuated, and it's not clear that there is much increased length of time for these patients. So that's it. Some of the experience I've had and how I discuss dialysis for patients with chronic kidney disease, with their patients and their families. If you enjoyed this video, if you made it to the end, I presume you enjoyed it. But anyways, hit like, subscribe, let your friends know, and until next time, thanks for watching.